Hello and welcome to the Emergency Care Improvement Programme Safer, Faster, Better webinar series. Number 3 today is Transforming Care for Frail Older People, and today's webinar will be delivered by Simon Conroy, a geriatrician at the University Hospitals of Leicester and the clinical lead for the Acute Frailty Network. Just before we start, there's a few simple housekeeping points. Just to remind you that this session is being recorded and the recording will be available to view on the ECIP website shortly afterwards. All attendees will be muted during the presentation to avoid background noise. And at the end of the presentation, there will be an opportunity to ask questions. If you do have a question, please use the raise your hand option in the panel on the right-hand side of your screen. Alternatively, you can write your question in the question section. Then, during the
I've just lost Emma. I can't hear you.
Hello, Tony.
Yep.
Would you like to start your presentation, please?
Okay, thank you. And thank you all for joining us today for this webinar on improving acute care for older people with frailty, who I'm sure you are all seeing on a regular basis throughout your hospitals throughout the country. Because of the changes in ageing demographics that mean that this is increasingly the customers that are coming through the front door. So, as was mentioned in the introduction, I'm a geriatrician in Leicester, but also work with the Acute Frailty Network, and we've run our first cohort of the Acute Frailty Network involving 10 sites across the country over the last year, just coming towards the end of that. And it's been a fantastic learning opportunity for us, and hopefully also for the sites that were involved, although you'll have to check with them. And from that work, we've basically drawn out some key principles that we think are important when managing older people with frailty in the urgent care settings. And they're listed here, so there's 10, which is handy because that's a nice round number, so we can all remember. And I think what will be the plan today is to go through each of these points in a little bit of detail over the next half an hour, just to give you a feel for what each of these means and how you might go about implementing these best practice principles in your systems across the country. So first is the identification of frail older people, and this is absolutely critical because frail older people in the urgent care setting represent a distinct cohort with high service use, so high long length of stay, lots of bed days, high readmissions, but they're also the cohort that, if we don't get care right, can come to harm. So there's patient harms associated with suboptimal care for this population, such as inpatient falls, secondary infections, deliriums, etc., etc. So this is a particular group of patients coming through your urgent care systems that needs particularly special care. Indeed, mortality in this population can be as high, if not higher, than some of the patients you might see in acute care bays or high dependency units, but often it's not recognised as such. And whilst many of them will be in the last 6 to 12 to 18 months of their lives, there will be many people that meet the frailty criteria that actually have acute intercurrent reversible illness. But even for those towards the end of their lives, an assertive early management plan, the strong links with the community can help ensure that dignity and quality of care are preserved during the context of their urgent care visit. So arguments there for really making sure that you identify this population. In terms of identification, there's a wide number of frailty scales that have been used internationally in a range of research studies, and they're all kind of much of a much, really. And none of them are particularly brilliant. None of them have an area under the curve of more than 0.7, which means as a diagnostic tool they're not sufficiently reliable or sensitive or specific to be used on their own as a means of directing clinical care. So, for example, you couldn't just screen for frailty, identify frail older people, and then zip them off to X, Y, or Z service. But it should prompt an early assessment of their needs, which we'll talk about more in subsequent slides. So, recognising that there is no perfect frailty screening tool, we've tried to be really pragmatic about using easily accessible criteria to identify a population in whom frailty is likely to be prevalent. And depending on how your system works, the two kind of options shown on the slide here are a reasonable way to start. So in the urgent care context, once you hit 85 years or older, we think most people, not all, but most people in that cohort are going to be frail. So that's an easy win because age is easily identifiable, it's routinely collected, and it's pretty unambiguous. And then obviously there'll be a lot of younger, older people, so those over the age of 65, who will have syndromes such as delirium or dementia, or come from backgrounds such as care homes that make them particularly vulnerable or associated with their vulnerability. And the other features there, fragility fractures, Parkinson's, possibly recurrent falls, all of which point towards a population in whom frailty is likely to be particularly prevalent. And in using those criteria, what we've always been bearing in mind is that we want the identification process for people with frailty to be somewhat independent of a complex clinical process. So it's aimed at the ward clerks, the nurses doing the stat assessments, the bed coordinators, that sort of level, so that everybody can identify frailty and then prompt that more detailed review which we'll describe, or direct patients towards services that can provide that more detailed review without having to wait for a consultant ward round or any sophisticated screening process to be undertaken. So it's basically really simple, pragmatic, easy to use criteria, and those that we've listed there are suggestions you might want to adapt them a little for your own setting, but we try to encourage people to make it really simple and easy so that the busy emergency department colleagues can identify these people very early on and flag them up to your frailty teams, which we'll discuss, with a view to starting early comprehensive geriatric assessment. There are some sites in England, particularly Cambridge, I think, who are starting to embed frailty screening tools in their routine processes, and if you can do that, that's fantastic. But again, as long as it doesn't become a laborious, time-consuming process that detracts from clinical care. So if you can have an automated system that identifies frailty, which is almost operator independent, but just flags these people up, then that's fantastic. And most people are starting to use the Rockwood score, which is an index which seems to work quite well in acute care. And there's a few studies that have been done to show that it does seem to identify a population at high risk of adverse outcomes. The other frailty phenotype that people may be familiar with is the free phenotype, which involves measurements such as walking speed and hand grip strength, which are really useful, but again, probably not easily applied in the acute care context. Looking ahead, there's work already been done by John Young, the National Clinical Director for Older People's Care, embedding frailty scores into System 1 and I think soon into EMIS, into the primary care system. So increasingly we should see frailty being identified in primary care and that then being communicated through to acute hospital settings when patients present. That's not yet routine, but will be coming in over the next few years hopefully. And we're also doing some work at trying to reciprocate that sort of automated flagging of frailty in hospital episode statistics, so that hospitals automatically identify people as frail using routine hospital data, and then can apply that flag so that people are identified as they come through the front door. But in the meantime, until those processes are in place, use your existing systems, EDIS or whatever it is you use, to create a frailty flag and have simple criteria that staff can use without too much complication to flag people that are likely to need a more detailed review. So identifying the population is really, really key, and as a ballpark measure, you can expect about a third of patients coming through an acute medical unit, for example, to be in that frail category. And so these are sort of lower volume, high intensity service users, as opposed to slightly fitter population who will be coming through, which is higher volume but perhaps slightly lower intensity without the multiple comorbidities, the cognitive impairment, the functional decline that characterises the frail population. It makes their clinical management that much more challenging. So first and perhaps most important principle, identification of this important cohort of patients. Having identified the population, we then need to think about what we're going to do with them. It comes under various guises, but the evidence base is referred to as comprehensive geriatric assessment, which many of you will recognise as just good quality clinical care. and if that's what you're delivering to this population, then fantastic. But it's important to check that CGA or comprehensive care for this vulnerable population is being delivered rigorously, routinely, and reliably. And in brief, it would ensure that we incorporate not just the medical sort of diagnostic and treatment aspects of the patient's care, but also make sure that we've assessed cognition, mental state, thinking about depression, which again is common in this group, identifying areas there, and obviously putting in plans to address that, whether it be during the acute spell or the through ongoing care in primary care once people are discharged home. But particularly with cognitive impairment, it's absolutely critical to identify the presence of delirium, not only because it carries an increased risk of mortality, but because it compounds the treatments that you might be offering patients. So obviously patients with delirium, hypoactive delirium in particular, less likely to be able to eat and drink themselves or need more help. They may not take sufficient fluids, become more dehydrated, more prone to falls because concentration is affected, and other harms in the inpatient stay. So that identifies a particular set of needs that need to be identified early, with clinical management plans put in place to address the delirium. Often we see patients presenting with functional impairment, by which I mean reductions in mobility, immobility off legs, those sorts of syndromes. And again, early mobilisation and a clear clinical management plan with discrete goals is an important part of assessing or drafting that patient's ongoing clinical care. Many patients will struggle because of social support, so lack of failure of social network support, if you like, and will need additional help once they go home as part of their recovery period. And also consideration needs to be given to the environment in which they'll be going. So it's not uncommon for patients to come into an acute hospital setting and then be transferred back out to an other setting, home-based or community hospital-based rehabilitation, and communication needs to be cognizant of that fact and ensure that patients' clinical management plans follow them through and are communicated to the teams that are going to implement those plans. And the key point really about comprehensive geriatric assessment, or this holistic approach, is to ensure that all 5 domains are addressed and incorporated into the clinical management plan. So you have to consider all 5 areas, and if you just focus on 1 or 2 or 3, then the chances are that you'll have a clinical management plan which is missing important aspects that will lead, if not addressed early, will lead to delays, long length of stay, and often clinical plans that don't quite meet the patient's needs. So if you do that already and you recognise this as good clinical care, fantastic, keep doing it, make sure you're focusing on the right people. But if you think that there may be areas where you could improve, then you'll need to start looking at how to go about delivering those improvements in your systems. By way of reassurance, the evidence base for CGA is very well established. There's several systematic reviews that have shown it's an efficient, effective and cost-effective way of delivering care to frail older people with urgent care needs. The next question is, having established that we want to deliver CGA, is how we go about configuring services to do so. And there's a tension here between breadth and depth of coverage, by which I mean you've got 2 general solutions, one of which is to embed geriatric services or services that can deliver comprehensive geriatric assessment within your acute medical unit or indeed your emergency department. Or there's the other alternative of creating discrete areas, or acute frailty units as they're sometimes known as, in which teams focus their efforts on delivering care to frail older people. Which of these is best will partly depend upon the local context and setup, and if your local urgent care system has a long-established system where there's a joint, integrated, well-working service that delivers CGA and acute medical care in parallel, then that's great. But often liaison type services or distributed services across the ANU do struggle to focus their efforts on frail older people, and it can be quite difficult to bring team members together and draw them together in a clear, coordinated, cohesive manner. So increasingly we're advocating establishing discrete ward areas or units in which geriatric teams, the multidisciplinary team, physios, OTs, nurses, doctors, etc., can all contribute to delivering CGA within a discrete area. And we find that the ward then assumes its own identity and the environment then can get modified and make it more frail friendly. The focus of the ward then becomes caring for frail older people, so teams are talking about frailty syndromes, how best to prevent them and so on. And it brings this clearer, sharper, more focused attention to the care of frail older people. And it also provides a bigger target. For example, if you're in the emergency department and you want to flag people as frail and you've got a unit to send them to, then that's a very clear clinical pathway which is easy for people to identify and follow. If it's a more diffuse service or amorphous service, then it can be that little bit more tricky to follow people through, which is really important because one of the other aspects is this point about assertive case management. So as people come through the system, they get this fantastic comprehensive geriatric assessment. How then do we ensure that that plan follows the patient and is delivered in an assertive, timely manner? Now this can be achieved through sort of integrated care pathways that ensure frail older people go to traditional sort of geriatric wards. But if patients end up on other wards where teams aren't perhaps as familiar with the management of frail older people, then it may be that some form of case management in reach is required to help ensure that plans stay on track and don't become derailed through misunderstandings or miscommunication. That can be quite tricky to deliver. You'd hope, wouldn't you, that the clinical case notes would be a sufficient vehicle to communicate the information necessary for ongoing care, but all too often that isn't sadly the case. And so increasingly teams or services are turning to teams of case managers, so nurse coordinators for example, who can follow frail older people through the system and ensure that the plans are adhered to unless of course the clinical needs change. And those plans will include aspects such as early mobilisation, which is absolutely critical because we know that patients staying in acute hospital settings who are immobile or bedbound that don't necessarily need to be will decompensate very rapidly and you lose significant amounts of muscle bulk over a few days, as well as proprioception, which means people are more likely to fall, and risk of hypostatic pneumonia, all those sorts of things which can be attenuated by early mobilisation. So unless patients are physiologically unstable and really sick, and the majority of these patients won't be, there are many of course, there are some who will be acutely unwell, who require high intensity care, but the majority will be presented with some form of decompensation of a long-term condition or subacute type illness, and early mobilisation is absolutely key. And again, back to the point about units versus diffuse services, an acute geriatrics ward or frailty unit that has that ethos of early mobilisation embedded in all of its staff caring for frail older people might be better placed than a service that has other competing priorities for its time and attention. Obviously, if you want to mobilise people early, then one of the key detractors from that process is tubes and catheters and cannulas and fluids and drips, so restraints in general. So if it's all possible, we try to avoid intravenous fluids when they're not absolutely needed for the clinical care of the patient, encourage oral fluids. Again, that reduces restriction, and clearly urinary catheters, again, often cited perhaps with well-intended but overzealously in frail older people to monitor strict urine output, which of course can be important, but often there are much better ways of assessing people's response to fluids such as blood pressure, pulse, temperature, using these clinical examination, etc. That means catheters may not be necessary. And aside from reducing the potential harms associated with restraining people with catheters, you also then, if you avoid them, reduce the risk of detrusor instability or catheter-associated sepsis. So avoid restraints. And the clinical criteria for discharge will draw upon the previous assessment, so the 5 domains of comprehensive geriatric assessment, to come up with an overall, not medically fit for discharge, but clinical criteria for discharge, or better still, clinical criteria for transfer to an ongoing setting. So these would incorporate the medical problems, but also the functional problems. So patient, Mrs. James will be able to go home and she's on all antibiotics, off IV fluids, able to mobilise 5 metres with a Zimmer frame, or once her acute physiological insult has become more stabilised, she could transfer to a community hospital setting for ongoing rehabilitation. So it incorporates those 5 domains. It might be nice to see features such as improvements in cognition or reduction in the psychomotor agitation as part of that plan. So an overall clinical decision or criteria for discharge or transfer, summarising the outputs of that comprehensive geriatric assessment. One of the ideas that we've toyed with in the acute frailty network but not yet managed to deliver routinely is kind of raising the profile of the care for frail older people in the urgent care setting, and we've adopted this idea of the silver phone, which talks to the agenda in the emergency departments about trauma calls. So if you're brought into an emergency department with a road traffic accident and have multiple trauma, you'll have a rapid response team involving an anaesthetist, a surgeon, orthopaedic surgeon, emergency department doctors, nurses, and so on and so forth. And everybody comes rushing down and peel off as the situation unfolds. So if you no longer need the anaesthetist, then they go back and do their day job and so on. And this is a really fantastic way of improving outcomes in trauma patients. But we don't see anything like that response routinely for frail older people who actually probably have as high, if not higher, mortality as some of the patients with trauma. And yet we know that if we deliver comprehensive geriatric assessment early and assertively, that we can improve our outcomes substantially. So the idea is to sort of have a silver phone whereby the team responsible for delivering comprehensive geriatric assessment, which may not necessarily involve a geriatrician, it just has to involve people with the relevant competencies, come flying in and assess frail older people assertively from the minute they hit the hospital, and then can peel off afterwards. So these ideas have been tested in some emergency departments up and down the country, and almost unanimously where they have been implemented, geriatric or CGA delivery services in the ED appear to achieve significant improvements in patient outcomes as well as service outcomes, with early supported discharge being the key metric there. So there's ideas that people can test to kind of raise the profile, but also improve care in the urgent care context for frail older people. The bane of any service is variability, and this is the same for geriatric services, it is for acute medicine services or surgery or whatever service you want to look at. And an approach to trying to reduce variability is to agree some internal clinical professional standards to which people should be working towards. So we've suggested here that CGA output should be completed within 1 hour, which is very ambitious. You may wish to adapt that for your own setting, but this speaks to that idea of the silver phone. If they're coming in, then we need to start the process as soon as we possibly can. We have suggested that people should speak to the agenda of the clinical criteria for discharge using a stratified problem list to highlight the urgent and important issues that need to be delivered upon in order to achieve good outcomes for this population. And those would be 2 hours overnight. That might be a junior doctor initially starting off that plan in conjunction with the nursing team, but 2 hours during the day and 12 hours overnight. So having clear standards that everybody can agree to and work towards is one way of reducing the variation. And of course, once you've agreed the standards, then you can measure them and determine how they're being implemented in your setting. One of the other vehicles for improvement in this population is a peer review of long length of stay. And if Ian Sturgis was on the talk today, then he would be talking about a 7-day cut-off. So patients over the ages staying more than 7 days should be reviewed, and almost a root cause analysis undertaken as to what happened, why they stayed so long, what could have been done differently at various points of the journey. It may be, depending on your setting, that 7 days is just an unmanageable number of patients. You might need to start perhaps for 10 or 14 days in the first instance. But the point here is that you identify a population who seem to be staying for a longer period of time than perhaps the top quartile of the population staying with long stays in the hospital, and then undertake a multidisciplinary review of their care, asking 2 key questions really. What could have happened differently in the first instance when they were admitted? Were there alternative options? Was the appropriate management implemented? Could they have been transferred to a community hospital or home-based rehabilitation services? But also look at the ward-based processes of care as inpatients and determine if anything could have been done differently to improve outcomes. So having standards and then measuring against those and using a quality improvement paradigm to help improve is critical. There's a summary here which we don't have time to go into in detail, but you might wish to come back to once the webinar is completed, but just really lays out in detail an example of a problem list based on a patient story, a very typical story of a person with a fall and delirium. And you can see here in concrete terms what we mean by a problem list, which has been stratified in terms of the order in terms of priorities, and incorporates both medical as well as cognitive aspects. So there's a stratified problem list for your consideration. I've already talked quite a bit about early supported discharge and links to community hospitals and other such services. Again, these were very, very much depending on your local setup. But behind the scenes, there need to be lots of conversation with other providers and partners in the system to ensure that pathways are clear. There are clear pathways in and out of hospital for frail older people. So many older people with frailty will require some form or other rehabilitation following an urgent care episode. Not all, but many. And so it makes sense to ensure that there are clear pathways out of the hospital. And those need to be really easy to access. So they shouldn't be complicated referral procedures, prolonged discussions. It should be a press a button, 2 hours later the patient's ready to go, and it almost needs to be at that level of speed, certainly in the urgent care setting, because of the rapid turnover of patients on wards, people getting out live, moved to areas where they suddenly get stranded and become more functionally more dependent, but also lose access to packages of care and so on. So if patients are stable enough to go out of hospital and there is a clear clinical management plan in place with which is time limited, then early discharge to or transfer to community settings where ongoing rehabilitation could be provided is key. And that clearly requires close collaboration between both acute providers and rehabilitation services or subacute providers in the community. So the diagram in there, the slide shows very simple, clear looking pathways, perhaps a little bit idealistic, but it should almost be that something you could draw out on the slide. And one of the mechanisms to make sure that there is clarity about pathways is the single point of access, so this so-called SPAR, single point of access, which ideally should be a clinician-to-clinician discussion, but often it can be quite difficult to achieve, but certainly there should be one point in the system that anybody can phone that allows patients to be directed onto intermediate care, rehabilitation settings as clinically appropriate, not multiple single points of access for various different aspects of the service. So simplify, make it easy, because these are chaotic, complex systems, and complex rules don't work. We've talked quite a lot about some of the operational priorities, but clearly ensuring that all frail older people with urgent care needs get access to comprehensive geriatric assessment in the way we've described it is important, and it's unlikely that geriatricians on their own are going to be the solution to this. Clearly the rest of the interdisciplinary chain are absolutely critical, but the numbers mandate that other clinicians are going to need, other doctors are going to need to develop their comfort and confidence in managing frail older people wherever they present in the system. So there's strategic initiatives here about improving undergraduate and postgraduate education, which obviously takes time to come through, and making sure that all people know how to manage delirium, know how to manage falls, know how to manage long-term conditions such as dementia, are comfortable with managing end-of-life care, all of these issues that are common in this population. But there are some shorter-term initiatives that could bring benefit, such as developing fellowships. So by way of example, we have some of our emergency physician colleagues in training who come and spend up to a year within geriatric services looking at both how to manage geriatric syndromes on geriatric wards, but also looking at the whole system. So they'll spend time in primary care, in community hospitals, various points on the frailty pathway that was outlined in the previous slide. And really getting a whole systems perspective on how to manage frail older people with urgent care needs. And that, is something to be put in place with collaboration and coordination relatively quickly. I think key is breaking down some of the perceived potential boundaries between different disciplines, different clinical disciplines, but also between acute and community settings. And whilst I've talked about doctors, obviously these sorts of initiatives apply equally well to therapists, nurses, anybody in the system really, so that staff start to spend time understanding the system from other people's perspectives, and that is a healthy and progressive way forward. We've alluded already to measurement, and lots of you will already be involved in quality improvement initiatives or have access to support to help you with your quality improvement initiatives. But with all the, one of the overriding principles is with all of these changes, don't just implement something because it sounds like a good idea. First of all, ensure that it's holistic in its conception, so that it's not just taking a single perspective on how to manage problem X, Y, or Z. But then put in place some measurements to ensure that it does what you intend it to do, because there often can be unintended consequences of changing pathways. And it's only if you have a holistic whole system perspective on any changes to your pathways and measure them that you'll be able to rectify. Hence the iterative approach of the measurement process. Who's going to do all this work? You might be asking yourselves. Well, of course you need some charismatic clinical change champions, but those people are few and far between and rapidly become exhausted if left on their own. So the point of this slide is to really highlight the importance of developing collaborative leadership that reflects preferably the whole system in changing your pathways and your processes of care for frail older people. It needs more than one person to be doing this, and it needs the whole system to be geared up and to support them in order to make the changes. And so urgent care boards, for example, would be a good place to start thinking about how to address the whole system pathway for frail older people. And finally, governance. So if you don't have underpinning senior support for these initiatives, underpinning and unwavering senior support for these initiatives, other priorities rapidly come into play and will detract. So having senior support from the urgent care board, from the executive team in the acute hospital, and the project management team that will help you deliver the changes, because this is big stuff and takes time, effort and patience, then you will struggle. And we've seen this with some of our AFN, our acute frailty network colleagues, who have had fantastic ideas but just haven't quite had the support that they've needed, and sadly some of those ideas then dissipate, and of course people become disillusioned and you're back to square one. So have the ideas, work them through in a whole systems manner, but ensure that there's a delivery vehicle so that they don't all dissipate into the distance. So there's our 10 principles. I've gone through them in a little bit of detail. The slides will be available to you afterwards if you want to look at them again. Summarised here for you. We also have a toolkit which is currently only available to Acute Frailty Network members that lends a bit more detail to this talk, but hopefully that will be becoming more widely available in the not too distant future. Thank you for listening. I think we'll probably have some time for questions, so I will stop and wait for the hands to go up.
Okay, thank you very much for that, Simon. If there is anybody on the line that would like to pose a question, please can you either select the raise your hand option or type your question into the box on the bottom of the screen. And we'll just give a moment for people to do that. Okay, can I ask colleagues, have we got any questions coming through at all, please? At the moment, Simon, it appears that you've stunned everybody into silence.
And I hope it was clear enough for people. But we'll have the slides online, won't we, if people want to go back over anything.
We definitely will do.
Simon?
Yep.
We've got a question. We've got a couple of questions. 3 questions now.
Right.
This one is from Jez Newton. And the question is, do you have an idea of how long it would take to pull these principles in place, starting from scratch, so to speak?
Wow. How long is a piece of string? So I guess if the commitment's there, if you start with the last 2 points, 9 and 10, if you've got clinical change champions that are eager, if you've got a system that's willing to support them in the change process and the project management's there, then a lot of these things can be put in place fairly quickly. Recruiting staff is always tricky, but there are ways around that. You can train staff up, you can move people from one position to another. So, and there will almost certainly be people within most systems that are capable of doing this sort of work. You just need to look at them and identify them. So doing all of it probably quite challenging, but you know, you could, if you've got the 9 and 10 in the right place straight to start with, then there's no reason why you can't get things like this up in at least started in a few months. But it needs that underlying commitment from the system and unwavering commitment to it as a priority.
Thank you, Simon. Was there another question as well?
Yeah, the next one is Peter Stokes. You're in the line with Peter to ask a question. Peter?
Yeah. Can you hear me?
Yeah, I can hear you fine. Do you like
Yeah. Okay. So, thanks very much. Really interesting. I'm from a GP provider, community interest company, and we're looking at how we look after, care, manage, and case coordinate the frail elderly in our community settings. And really, my question was, how do you see the acute elements of this interacting with our integrated care being delivered by integrated care teams operating in the community?
Yeah, so the acute episode is a small part of obviously the patient pathway. You know, it's small percentages in terms of the days that people are on the frailty pathway in the overall scheme of things. And so having strong support from community services that will provide the bulk of the ongoing care for this population is absolutely key. So I think part of it is about how you communicate across that interface, and I think we still struggle big time in most places to effect meaningful communication between acute and community providers. Lots of initiatives have been undertaken, system ones available in hospitals, but actually it's still quite a struggle sometimes to get communication between acute and community settings going. So things like, you know, we talked about a single point of access is one important vehicle, and then the acute providers can connect to the community services through that single point of access. Having locality coordinators that can come in and take, you know, have responsibility for a local population that can reach in and come and speak to the clinical teams about what can and can't be done in the community setting, perhaps pinned around individual patients as to make it a sort of a real consideration, make it clinically relevant. So communication between those two is absolutely critical, because obviously if the acute sector send people out with inadequate information or even worse, misleading information, then the community services are going to struggle to pick up the pieces. But you know, apart from making it simple through, for example, a single point of access, making it consistent and making it clinically meaningful. Don't have a magic wand, I'm afraid.
Thank you.
Okay, thanks for your question, Peter. We now have Maggie.
Hi, yes, I had a couple of questions.
Oh, I'm missing bits of that. Sorry, Maggie.
I was just asked with my listening hat on, what drivers and emotions have we got to encourage trust to adopt this kind of model?
I don't know if Emma or Lisa heard that better than I did and can summarise the question again.
Simon, I muted Maggie, but Maggie, I'll ask the question for you. Let me take it.
Thank you.
There's two questions. The first one is, what enablers and drivers can clinical commissioners use to drive change in acute care?
No, do that again. What enabled?
What enablers and drivers can clinical commissioners use to drive change in acute stress?
Okay, I think what I've understood is the question is what drivers do the CCGs have to facilitate changes along the lines that we've just been discussing? Is that right?
Yeah.
Okay. I think that the CCGs in particular have a very clear role in terms of making sure that frail older people are prioritised within the acute hospital setting. Speaking to the ideas we talked about earlier on about identification and so on. So you might use, for example, either contracting or perhaps even sequins to flag, ensure that frailty identification is being undertaken, and then CGA being delivered. And that's all very measurable, so it would lend itself well to things like a sequin initiative over the course of a year, perhaps, to ensure that A, frailty is being identified and B, being delivered. But they also have a really important role through the urgent care board to ensure that it becomes the core business and that the system is thinking about the services that are being configured from the frail older person's perspective, which I'm sure lots of people are doing already, but sometimes that does get lost in the narrative. And of course the advantage of that is that if you focus on frail older people, then almost by default the rest of the system will get better, because what's good for this population will be good for most other people as well. But the converse doesn't always apply. So a focus just on sort of the high volume, low intensity population won't necessarily lead to system changes. The other thing I think the CCGs can do, which in my experience is sometimes difficult but absolutely critical, is to foster good relationships between providers. So in big systems, indeed in any system, the silo mentality, the sort of protectionism, which is going to get all more difficult under the current financial constraints, if you like. So bringing together NHS providers and social care to agree working in a collaborative way would be really, really important. And that doesn't necessarily have to be a formal contractual vehicle, or integrated organisation. It means that I think the key is really developing trust and sharing risk across the system, and CCGs can lead the way in that regard.
Okay, thank you, Simon.
And the other half of the question I've forgotten or didn't hear, sorry.
No, that's fine. I'll read that out. You might have that already. Maggie's other question is, how can primary care best contribute to the frailty agenda? A lot of information seems to be available for commission and available.
The acoustics are rubbish. How can primary care best contribute to
the frailty agenda?
Frailty agenda. Primary care as in GPs on the ground, or primary care services on the ground, I'll assume that to be. I think, gosh, that's a big question. So I think if you haven't already, sign up for John Young's frailty identification tool, which is, I think, being rolled out. It's in System 1 already, and it's about to be rolled out into EMIS, I think. So that will allow you to identify frail older people in primary care, like you do currently with the 2% people that are on registers for end-of-life care and things like that. So make sure that they're identified as a population. And then there's once you identify frailty, of course, I've been primarily focusing on people with moderate to severe frailty, but there are different scales of frailty. So people with mild frailty may only need some support with self-management, and you might be doing a lot of that already as part of your routine care, and that's fantastic. The second sort of moderate frail population might be those that need more of a case management approach, try and coordinate, communicate care around and ensuring it's holistic. So thinking about the 5 domains, making sure that we've addressed all of those. So mild frailty would be self-management, moderate frailty, case management, and then the more severe frail population, for example, those people in residential care homes, residential nursing homes, you might want to think about more heavyweight treatment intervention based on the principles of comprehensive geriatric assessment. So this would start looking at things like medication reviews under life care plans, future care plans, managing cognition, all those sorts of things that we've touched upon already. So I think the biggest ask from primary care is to identify this population, be aware of what their kind of vulnerabilities are, and then put in an appropriate intervention, whether it be self-management, case management, or a more comprehensive management plan once you've identified them.
Okay, thank you. We've got another question from Bev Willis. Bev, would you like to answer any question? No, I can't hear Bev at the moment, so I'll read the question out for you. It's, have you examples of a rapid CGA that works within ED?
Oh, right, okay. Yes, so CGA is, if you like, is the paradigm, the principles within which we operate. And clearly, following a comprehensive assessment, some people will require ongoing care, and that might be delivered in their home settings, it might be delivered in acute hospital settings, but the initial CGA process can take place in the emergency department in the same way that any other assessment process takes place. So it doesn't have to be a long, drawn-out, convoluted package of care or a care intervention that takes days, weeks, and months to deliver. The initial assessment in the ED need only identify the key clinical priorities the patient needs to, that are required in order for the patient to progress through to the next stage of the system. So you can sit in an emergency department, have older people, frail people assessed, identify that they need treatment X, Y, and Z, physiotherapy and some district nursing to help with their pressure sores, and they can go home. So it's using the CGA approach to organise the care for that patient. In terms of how you deliver that in the ED, well, we have examples in Leicester, for example, where we have a team of primary care coordinators who are nurse case managers with special expertise in frailty management, who will help to contribute to that holistic assessment. But I'd love to get to a day where actually, in the same way that emergency physicians and departments are brilliant at recording GCS, EWS, whatever other early warning score you want to mention, actually their assessments also incorporate the elements of CGA. So the initial assessment process can be done very, very quickly. It doesn't have to take a long period of time. The ongoing management obviously will depend very much on the patient. So some patients will require prolonged periods of rehabilitation, which are clearly inappropriate in the ED setting and will need community services. Others actually may need to come in for acute care. So I think the point that is important to take away from this is that the sooner we identify and prioritise the problems from a holistic whole patient perspective, rather than just simply focusing on condition-specific issues, pain and negative can go home type thing, the better. And the emergency department is a critical part of the system to help us deliver that.
Okay, we've got another question from Rachel Preston. I'll just unmute you, Rachel. Let's ask your question.
Yeah, I'm again struggling a bit to hear, but I'll do my best.
Okay, can you hear us, Rachel? Okay, I don't think Rachel can hear us, so I'll ask the question for her. how long does a comprehensive geriatric assessment take? Could some of it already be available from the community record the knowledge of the patient and therefore speed it up?
Yeah, yeah. So it's a misnomer, this comprehensive geriatric assessment thing, because it's not just about the assessment, it's about the ongoing management. But that's what it's called in the literature, and that's what it's recognised as internationally, so we'll stick with it for now. But the assessment process itself doesn't need to take very long. I mean, the idea is that you identify something with frailty, and then you go through the domains as outlined in the talk, and identify if there are issues within that domain, and if within each of those domains. So, and if you ask someone, how's your memory, and they've got no problems with their memory, and they're not delirious, and the carers are sitting next to them nodding, saying absolutely fine, then you move on to the next domain. How's your mobility? Fine, I get up and down the stairs, I get out to the shops. Great, move on to the next one. How's things at home? All well supported? Yes, etc., etc. So it could take, minutes potentially to rapidly go through the domains of CGH, and obviously in patients that don't trigger on any of those, then it's relatively straightforward, and you deal with the problem as it presents, the primary problem, and let they go to wherever they've come from. If patients do trigger in those domains, then usually what you'll find is that they trigger in multiple domains. So sort of frail older people tend to save it all up and present with everything all at once. So if you've got problems with cognition, you'll often find there's problems with functional mobility, continence, etc. And in that case, the assessment process will still be relatively brief. So we're talking minutes to half an hour or so. It shouldn't take any longer than that. It can be incorporated into routine clinical assessments. The ongoing management, however, will take longer depending on that individual's clinical needs. So it's a sort of how long's a piece of string thing. But the key point is it's an iterative process. So you do your initial assessment, you identify the issues that need to be managed with that stratified problem list, you document them, and then you work through them and iterate through it if things change.
Okay, thank you ever so much for that, Simon. I've been informed by the team that we don't have any more questions lined up. Okay. So it just remains for me to say thanks ever so much to everybody for dialing in, and to you, Simon, for taking the time to give the presentation. If anybody does have any more questions, if you'd like to send them through to our ECIP info email box, that's ecipinfo@nhselect.org.uk, and we'll pass them on as appropriate. Just a quick reminder that we have recorded today's session, and we will get this up on the website as soon as we can. Otherwise, it's goodbye from all of us here, and thank you once again for joining.
Thank you. Bye-bye.